everyone, this is Ayushi Chavan from DUPMC Jalgaon, and today we are going to learn about pharmacokinetics, metabolism and excretion of drugs. In this, the topics to be covered are excretion, renal excretion, kinetics of elimination, Plateau principle, prolongation of drug action and targeted drug delivery system. Excretion, it is the removal of systematically absorbed drug. Drug is removed via urine, feces, exhaled air, sweat and saliva and milk. Renal excretion. All water-soluble substances are excreted via kidney. The amount of drug present in urine depends upon the total of glomerular filtration, tubular reabsorption and tubular secretion. So basically, net renal excretion is equal to glomerular filtration plus tubular secretion minus tubular reabsorption. Glomerular filtration. It depends on its plasma protein binding and renal blood flow. Tubular reabsorption. It occurs by passive diffusion and it depends on lipid solubility and ionization of drugs. Rate of excretion of drugs parallels GFR. Changes in urinary pH affects tubular reabsorption of drugs that are partially ionized. Weak bases ionize more and are less reabsorbed in acidic urine. Weak acids ionize more and are less absorbed in alkaline urine. This principle is utilized for facilitating elimination of drug in poisoning. The effect of changes in urinary pH on drug excretion is greatest for those having pKa value between 5 to 8 because only in their cases pH dependent passive reabsorption is significant. Tubular secretion. If renal clearance of a drug is greater than 120 ml per minute GFR, additional tubular secretion can be assumed to be occurring. Active transport of the drug across tubules reduces concentration of its free from the vessels and promotes dissociation of protein-bound drug, which then becomes available for secretion. Organic acid transport operates for penicillin, probenecid, uric acid, salicylates, indomethacin, and etc. Organic base transport operates for thiazides, furosemide, and quinine. Both transport processes are bidirectional. Drugs utilizing the same active transport compete with each other. Many drug interactions occur due to competition for tubular secretion. Example, aspirin blocks uricosuric action of probenecid and sulfenpyrazine and decreases tubular secretion of methotrexate. Quinidine decreases renal and biliary clearance of digoxin by inhibiting efflux carrier PGP. Kinetics of elimination. Clearance. The clearance of a drug is a theoretical volume of plasma which the drug is completely removed in unit time. It can be calculated as Cl is equal to rate of elimination by C, where C is the plasma concentration. First order kinetics. The rate of elimination is directly proportional to the drug concentration. Cl remains constant or a constant fraction of the drug present in the body is eliminated in unit time. Zero order kinetics. The rate of elimination remains constant irrespective of drug concentration. Cl decreases with increase in concentration or a constant amount of the drug is eliminated in unit time. Example, ethyl alcohol. The elimination of some drugs approaches saturation over the therapeutic range. Kinetic changes from first order to zero order at higher doses. Blood flow dependent elimination. For few drugs, the eliminating capacity of an organ of elimination, kidney, liver, far exceeds the amount of drug normally presented to it by blood circulation. The elimination of such a drug becomes blood flow dependent. Plasma half-life. The plasma half-life of a drug is the time taken for its plasma concentration to be reduced to half of its original value. The plot has two slopes. Initial, rapidly declining alpha phase due to distribution. Later, less declined beta phase due to elimination. T half is equal to ln 2 by K. K is equal to Cl by V. T half is equal to 0.693 into V by Cl. Nearly complete drug elimination occurs in 4 to 5 half-lives. Repeated drug administration. When a drug is repeated at relatively short intervals. It accumulates in the body until elimination balances input and a steady state plasma concentration is attained. After oral administration, only a fractional reaches systemic. Plateau principle. When constant dose of a drug is repeated before the expiry of 4 T half, it would achieve higher peak concentration because some remnant of previous dose will be present in the body. This continues with every dose until progressively increasing rate of elimination balances the amount administered over the interval. This is known as the plateau principle of drug accumulation. Steady state is reached in 4 to 5 half-lives unless dose interval is very much longer than T half. The amplitude of fluctuations in plasma concentrations at steady state depends on the dose interval relatively to the T half. That is, the difference between the maximum and minimum levels is less if smaller doses are repeated more frequently. Target level strategy. For drugs whose effects are not easily quantifiable and safety margin is not big, it is best to aim at achieving a certain plasma concentration which has been defined to be in therapeutic range. Such data are now available for most drugs at this type. Loading dose. This is a single or few quickly repeated doses given in the beginning to attain targeted concentration rapidly. It may be calculated as loading dose is equal to target Cp into V by F. Maintenance dose. This dose is one that is to be repeated at specific intervals after the attainment of target CPSS so as to maintain the same by balancing elimination. Such two-phase dosing provides rapid therapeutic effect with long-term safety. Monitoring of plasma concentration of drugs. Measurement of plasma drug concentration can give an estimate to pharmacokinetic variables in that patient and the magnitude of deviation from the average patient so that the appropriate adjustments in the dosage can be made. Revised dose rate. Previous dose rate into target CPSS by measured CPSS. Therapeutic drug monitoring is particularly useful in the following situations. Drugs with low safety margin. If individual variation are large, potentially toxic drugs are used in the presence of renal failure, in case of poisoning, in case of failure of response without any apparent reason, to check patient compliance. Monitoring of plasma concentration is of no value for drugs whose response is easily measurable, drugs activated in the body, hit and run drugs, drugs with irreversible action. Prolongation of drug action. It is sometimes advantageous to modify a drug in such a way that it acts for a longer period. By doing so, frequency of administration is reduced, more convenient. Improved patient compliance. A single morning dose is less likely to be omitted than a 6 or 8 hourly regimen, a monthly or quarterly administered contraceptive over one that has to be taken daily. Large fluctuations in plasma concentration are avoided. Drug effect could be maintained overnight without disturbing sleep. First, by prolonging absorption from site of administration. In this, oral, sustained release tablets, capsules, etc., drug particles are coated with resins, plastic materials, or other substances which temporarily disperse release of the active ingredient. Semi-permeable membranes to control the release of drug from the dosage form. Second, parenteral. The SC and IM injections of drug in insoluble form, biodegradable implants, can provide for its absorption over a couple of days to several months or even years. Third, transdermal drug delivery system. Second, by increasing plasma protein binding, drug conjugates have been prepared which are highly bound to plasma protein and are slowly released in the free active form. Third, by retarding rate of elimination. Inhibition of specific enzymes by one drug can prolong the action of another drug. Fourth, by retarding renal excretion. The tubular secretion of drug being an active process, can be suppressed by competing substances. Targeted drug delivery devices. Some new devices have been invented to localize and prolong the delivery of the contained drug to a specific target organ. The ones in already use are liposomes. These are unilamellar or bilaminar nanovesicles produced by sonication of lecithin or other biodegradable phospholipids. Since liposomes injected IV are selectively taken up by reticuloendothelial cells, especially liver and spleen, and some malignant cells, the drug incorporated in them gets selectively delivered in these cells. Liposomal amphotericin B is being used in Kala Azar and some serious cases of systemic mycosis. Antibody tagging of liposomes is being tried as a means to target other specific tissues. Second, drug releasing implants. The implant is coated with the drug using special techniques and then placed in the targeted organ to provide prolonged delivery of minute quantities of the drug by slow release. It is also being tried for other gynecological problems. Antithrombic drug coated stents are in use to prevent restenosis and failure of angioplasty. So with this, we complete our topic. Here are some multiple choice questions. First, glomerular filtration of a drug is affected by its A. Lipid solubility, B. Plasma protein binding, C. Degree of ionization, D. Rate of tubular secretion. Second, the plasma half-life of penicillin G is longer in the newborn because of their A. Plasma protein level is low, B. Drug metabolizing enzymes are immature, C. Glomerular filtration rate is low, D. Tubular transport mechanisms are not well developed. Third, if a drug is eliminated by first order kinetics, A. A constant amount of the drug will be eliminated per unit time. B. Its clearance value will remain constant. C. Its elimination half-life will increase with dose. D. It will be completely eliminated from the body in 2.5 period time. Fourth, the loading dose of a drug is governed by its A. Renal clearance, B. Plasma half-life, C. Volume of distribution, D. Elimination rate constant. And the fifth question is sustained or controlled release oral dosage form is appropriate for the following type of drug. A. An anti-arthritic with a plasma half-life of 24 hours. B. A sleep-inducing hypnotic with a plasma half-life of 2 hours. C. An antihypertensive with a plasma half-life of 3 hours. D. An analgesic with a plasma half-life of 6 hours used for relief of casual headache. These are the questions. You may go through them. Thank you.